Welcome everyone. Thank you so much for being a part of today's session where we're going to take a deep dive into thinking about how do we build mental health and wellbeing across South Australian vulnerable communities. Today's session is hosted by LBI Foundation, and both myself and David Kelly will be working together to keep everything on the road and keeping a really structured, focused conversation and really drawing your insights into it. We're lucky enough today to have two keynote speakers. First of all, we have Professor Sharon Lawn from Wellbeing SA, who's also the South Australian Mental Health Commissioner. Oops, sorry, wrong forward. And also Matthew Iasiello from SAHMRI, who's a researcher who's going to give us a really nuanced view of the relationship between wellbeing and mental health. Today's session, I've just introduced it, but before we kick it off, I would like everyone to bring some mindful awareness of the importance of meeting the lands of the local people from their area today. I'd like each and every one of you to bring some mindful awareness of the significance of meeting of the lands of the local people. Thank you so much. We're really asking each and every one of you today to draw upon the concept of mindful awareness, or just being aware, as a really core cornerstone of how we think about mental health and well-being, and where possible, really give yourself permission to bring some boundaries, or allow yourself to immerse yourself into this topic in a way that you can free yourself from distraction. I appreciate that many of you have got competing tasks around you, but where possible, really be a part of today's conversation. Today's conversation is going to focus on 5 key areas. The first one is looking at wellbeing and mental health, and really what does this mean in action? How do we construct it? We're then going to work towards understanding lived experience. We're going to work towards looking at the existing and emergent vulnerable community members. We're going to think about those proactive, preventative strategies to build mental health and wellbeing. And then we're going to hear where South Australia is heading in terms of strategic directions. So we're going to focus on these 5 areas today, and you're going to be very much a part of the conversation, where we're going to draw upon polling and other mechanisms to draw upon the participant group to make this a really rich conversation. Before we kick it off, I thought I'd just do a quick overview of LBI Foundation, who we are. I'll just give you a couple of background slides here. So LBI Foundation is a public benevolent institution really dedicated to building the mental health and wellbeing of Australians in need. And our approach is very much about empowering and growing local capacity. What does this mean? Well, we're really interested in communities, a community being a region, a school, a care team, a work group. And capacity is really focused on this. How do we understand and respond to those deeper needs that drive wellbeing and mental health outcomes? But how do we also build individual and collective capacity across our communities? As an organisation, we are different, and we seek to work side by side with individuals and communities in the following ways. We really want to draw upon the science of wellbeing and resilience, but integrate that with the local wisdom strengths of individual communities. And today's session is really about this. We're going to hear from some best practice science, but we really want you to be thinking about how you can draw your wisdom into this and operationalise the content for your context, in a way that we can always personalise the science of wellbeing with your wisdom to individual local needs and context. Everyone in today's group is coming from a different context, and we really want you to think about how can you apply it for your context. As an organisation, how do we do this? Well, we do draw upon the method of intentional practice, which is a method which has been developed through my PhD and also supported for a number of collaborations, including with a number of people who are supporting today's presentation, David Kelly and also Matthew Iasiello. But we also draw upon the impact program, which is a methodology which draws upon the science of wellbeing, positive education, positive psychology, trauma-informed practice and implementation science. As an organisation, we focus on the following services, and this is my final slide. We do specialist training and coaching. We also have an impact coach network. These are a group of people embedded within their local communities who draw upon the science of wellbeing and support them and coach to make a difference in their community. We also work through whole of community approaches, whole of community therapeutic, whole of community wellbeing, or trauma-informed practice. And we focus on 3 key initiatives. At the moment, our work is streamed through the area of resilient impact, which is a focus on education, care impact, which is child protection, and community impact, which is around wellbeing and mental health outcomes across broader communities. We have public access resources, and we also focus on community seminars and forums. And today's session is linked to the bottom one. So that's who we are as an organisation. I'm now going to allow the panel members to individually introduce themselves, and then we're going to work to really getting into the topic. I'll just stop the share for a moment. So just a quick background to myself. I'm obviously a clinical psychologist by trade. I have a background in really working in youth work and child protection. So I started my journey in the context of the child protection system, worked in Families SA many years ago, then worked to set up an agency called Connected Self, which was around integrating youth work and psychology. Further from that, I did a PhD, and now I'm really interested in how do we build mental health and wellbeing outcomes, drawing upon a really practical-based approach. In some ways, that's a youth worker in me. The psychologist in me wants to bring frameworks or ideas which hold that together through evidence, and the researcher in me wants to ask the question, are we making a difference? And what brings that together is the art of being intentional. And that's a methodology that LBI Foundation and myself really advocate for in how we think about building mental health and wellbeing outcomes. Being really intentional around design and implementation of our work, both at the system level, but all the way to moment caregiving and support. I'm now going to hand over to Sharon, who's going to introduce herself.
Hi everyone. Thank you, Ivan and LBI, for inviting me to come along today. It's a great pleasure. I've started in the role of Mental Health Commissioner in early January, so it's a fairly new role. I've come from a range of backgrounds, so I was working at a university and still do for a long time, and also a long time as a clinician. I'm also a family carer and a lived experience commissioner, so I'm a bit of a range of a few different hats. Thanks, Ivan.
Thank you so much, Sharon, for that introduction. I'll now hand over to Matthew.
Oops, sorry. Hi everyone, my name is Matthew Iasiello. I'm working at the Wellbeing and Resilience Centre based at SAHMRI. I've been there for almost 5 years now, and in that time worked very closely with both David and Ivan on the at-risk youth program Resilient Futures, and have worked across a range of different projects designed to improve the wellbeing of various cohorts across South Australia. At the same time, I'm a Flinders PhD student, focused on the relationship specifically between mental health and mental illness, and investigating what that could mean for our mental health care system if we started embedding wellbeing into it.
Thank you so much, Matthew, for that. And I hand over to David.
Good morning, everybody, and thanks so much for making the time to join with us today. I've spent my career, which is considerable, working with vulnerable communities of all sorts and working with them to improve the capacity for better mental health and wellbeing outcomes. It's my privilege to be working alongside Professor Sharon Lawn as a co-commissioner. But it's also my honour to be part of the LBI team as well. So I wear a couple of hats today, and I'm really looking forward to a very exciting session.
Thank you so much, David, for that, introducing yourself. What I'm going to do now is to really capture the audience participation. I'd like to initiate a poll just to get your feedback around what you'd like to get from today, what's of most interest, but also to get a bit of a summary flavour who's sitting in our group. So I'm going to share this poll. So I'm hoping everything, all technology is going to work. So this is about a minute poll. So, you know, we're asking where you're located, and there's some regions there. You know, what is the main role or hat you're engaging with this webinar on, whether you're a caregiver, teacher, support worker, researcher, or just an interested party, and what a topic attracts your greatest attention. And those topics there really focus on the topics of between mental health and wellbeing. What's the relationship? What role does lived experience have within this? Who are those emergent and existing community members? What are best practice strategies? And how do we think about strategic directions? So we'd really love to get your feedback here. This is your opportunity to, to be a part of the conversation and for us to also get a sense of who's sitting in the room today. I'm going to give you another, probably another 20 or so seconds to do this. There'll be a number of polls today, and we do ask that people, as best you possibly can, really respond fairly quickly. We're nearly at 50% at the moment. So we'll just keep moving forward. There's lots of polling coming through. We're up to 81 attendees. We've got a few more people coming through. We're up to nearly 60 responses. I'll give you another 5 or so seconds, and then we'll give people some feedback of where they are sitting in the world. All right, so 5, 4, 3, 2, 1. All right, so just quickly push if you can. All right, we got to 82%, so we've done pretty well there. I'll just share some of the results. So we do have a high contingent from Metropolitan Adelaide today, but also we've got people from all around South Australia, which is great to see. I guess we have a number of the main hats that people are wearing today is that support worker, practitioner, professional hat. Also have some caregivers in the room as well. What's attracting people's attention? Well, there's always a bit of a mixed bag here, but definitely that preventative sort of strategies is where people want to head today. So that's good for us to know as a facilitation group. All right, thank you so much everyone for sharing that, and we'll hear from you as we go along further along the day. All right, now. So I'm going to reshare my screen, and this is going to give us a bit of a spring shot into the first content area today. We've done. So, all right, so this is the 5 areas we're going to cover, and we're going to look at the first one, the relation between wellbeing and mental health. And just to let you know how the format's going to work, so this is just giving a bit of a scaffold in your mind about what you can expect. We're going to briefly set the scene very quickly. We're going to try to engage you in a poll to get your feedback. We're then going to give you an upfront question to consider or reflect upon. We're then going to hear from our expert panel, and then we're going to explore your questions and comments, and then we're going to work towards some summary themes. So this is how we're going to navigate ourselves through today. All right, so we're looking at the relation between wellbeing and mental health and the multiple constructions of wellbeing. And this is probably one way that we can think about this relationship. It's a bit of a mess sometimes. Mental health and wellbeing is quite complex, and I wish there was an easy solution. But we're going to try to disentangle this complexity today and give you some insights which you can take forward. But what I really like about this diagram as well is that how we think about this, we are actually joined up with the construction too. We can't completely separate ourselves out. So it's always good for us to consider that this is complex, and each and every one of us brings a different frame of reference, and we are not completely separate to how we look at this ourselves. So I'm going to engage in a very quick poll just to get your feedback around how you think about mental health and wellbeing, and then we're going to introduce the reflective question. So we're going to ask you the question here. How would you describe wellbeing? And find an answer that best matches your view. Is it about good physical health? Is it about feeling good? Is it about mind, body, spirit, PERMA, happiness, wellness? Is it the absence of mental illness? Is it life satisfaction and contentment? Is it about meaning and purpose? Or is it something that is personally defined? So we'd like to give you another 15 or so seconds to reflect upon this question, and it's really interesting to see what the collective group thinks. All right, so we're just ticking up to 60%, so we can see we get a little bit higher.+Thank you all for voting, and I'll show you the results. It's always nice for us to get a bit of a sense of what people are thinking about. Again, we're up to 80+%, so we're doing well. I'm about to give you 5 more seconds. 4, 3, 2, 1. All right, we nearly got to 90% that time. Yep, there's a bit of feedback from some people that they can't see the polls. Every time in Zoom, there's a little bug which comes out where some people can't see it. I can't explain why. So I'm going to share the results. How do people think about wellbeing? mind, body, spirit is the #1 construction that people have come up with. There's some PERMA people: happiness, wellness, life satisfaction, and also there's something personally defined. All right, so thank you all for sharing that. All right, I'm now going to hand over to David, who's going to give us a question to consider, and then we're going to hear from our panelists, and then we're going to explore this collectively. I'll hand over to you, David.
Okay. Thanks very much, Ivan. Look, it's so wonderful to see such diverse representation in the webinar. You truly are the experts in this space, and we want to draw on your expertise to really encourage you to use your knowledge, your experience, use the ideas that are coming through from our 2 keynote speakers to really, as Ivan said, develop a very rich conversation as part of our webinar today. Now, one of the ways that we're going to do that is by, at the commencement of each section, put out a question for you that we would really encourage you to keep at front of your mind as you're listening to our keynote speakers. So the first of the questions that we really want you to consider as we move into our first presentations is how do you understand wellbeing and mental health? Now, that's from the context of your community, whether that's your program, your agency, the community that you live in, the region you work in. However you want to define that's fine with us. So how do you understand and talk about wellbeing and mental health? And I guess most particularly, how do you describe them? Are they different, or do they sometimes become conflated in our discussions? Also, the one other point that we want to make is we'll be exploring this in much more detail over the course, but it's these 2 notions of wellbeing promotion and mental health prevention. We want you to keep that front of mind as well. So I think, Ivan, now back to you.
All right, thank you so much, David. So we're now going to hear from Matthew, who's going to provide us a really diverse look at wellbeing and mental health. So I'm going to stop the share and hand over to Matthew.
All right, awesome. Just give me 1 second to share my screen. Fantastic. So thanks, everyone. So like I said, I work at an organization called the Wellbeing and Resilience Center in SAHMRI. So we've spent a few years now really tackling with these questions that Ivan and David have posed. Basically, what I wanted to do to start off with was just to talk about sort of how we think about mental well-being at our organization. And this is based on the research evidence. So there are a lot of different models out there, and researchers like to think that whatever they came up with is the best one. But generally, what we see is when you look at all the models of well-being that are out there, these are the things that always pop up. And these are the research bodies that have a lot of evidence behind them. And so I've got some photos of the researchers that came up with them too here. But basically what we see when we talk about mental well-being are these 3 themes. The first one being subjective well-being. So sort of how well do you feel? Are you satisfied with your life? Do you have more positive emotion than negative? Then there's this idea of psychological well-being. So this is like, how well are you functioning in life? So this is about finding purpose in life, personal growth, positive relationships, these sorts of things. And finally, there's social well-being. So of course, we all know here that we're not just individuals in the world. We have to be connected and feel like we contribute to and understand the community around us. And I really like that poll that just came out because one of the answers there, which I think a lot of people voted for, was about well-being as something that's personally significant to you. And I'd like just to point to this idea of purpose in life under psychological well-being. And the reason why I do that is to say that we know from the research perspective that purpose in life, having a sense of meaning, is very important to individuals, but that doesn't prescribe what it is that you find purposeful. So I just wanted to sort of talk about that idea of where the research sits in and how that relates to personal understandings. So basically, when we think about the relationship between illness and health, we've traditionally thought about it looking a little bit like this, sort of like a one-dimensional number line where -10 is mental illness, 0 is sort of like a neutral state, and then +10 is higher levels of well-being. And the idea was generally that if we could shift people across this line, and that's sort of like a population curve, if we can push people across, that we're taking more people out of mental disorder and into flourishing levels of mental health or well-being. What that's meant is that we've had a mental health service traditionally focused on improving quote unquote sick people or mentally ill people from -10 to 0. And as positive psychology and some of these other well-being programs have come out, we've then sort of extended that number line to get people from negative to +10. Some issues with this model is that it treats people as either mentally ill or mentally healthy, and sort of suggests that you can't be one or the other. And it's sort of an untested assumption. So when this assumption was tested, this is sort of how we started to see the relationship between well-being and illness. We see, first of all, over a range of studies that mental well-being is not merely the opposite of mental illness, that they're actually two separate things. And we see in the evidence that individuals can experience higher levels of mental well-being, even with the diagnosis of a mental illness. And what this means is that you can shift the priorities of that more deficit-focused system to one that starts to include prevention and promotion. We like to really draw on this idea of how we think about our physical health. We know that somebody who is sick, with a cold or with the flu, say, for example, just because they are diagnosed with an illness doesn't mean they can't still focus on their health. So someone who might have, a really bad cold could still be focusing on their sleep, focusing on getting a little bit of physical activity, eating well, taking vitamin C, those sorts of things. And that's the way the research shows is a more useful and more evidence-based way to think about illness and health, that they're two separate things. Basically, this is a bit of a silly slide, but when we think about this model of mental health, where you've got the two continua there, what we also see is that there are different people in a population. People like Bugs Bunny, who have a high level of well-being without the diagnosis of a mental illness, they're doing really well. We have the Eeyores of the world who might have both a low level of well-being and a mental illness or high levels of distress. We have the SpongeBobs in the world, who are people who might function very well despite their mental illness. And this obviously applies to developmental issues and to addictions as well. And then we have this guy from Old Gill who are doing poorly in terms of their well-being, but wouldn't necessarily be diagnosed with a mental illness. So I'll come back to Old Gill in a moment in a later section. I think that's about my time there, Ivan. So thank you.
All right, thank you so much, Matt, for that. I'll just get you to stop the share of your screen, and then we'll hand over to Sharon. But I guess what Matthew has really done here is starting to get us to think about mental health or mental illness as being separate to well-being. And as a psychologist who's been trained, I was trained to conflate these. And what the work of Matthew has really done for myself is getting us to think about, you can have a mental illness, but you can also have high levels of well-being. These are not necessarily the same concepts. So that's the really key take-home message I hold on to. So I'm now going to hold on to, so I hand over to Sharon.
Okay, thanks, Ivan. I'm hoping people could excuse me. I'm going to read for some notes so that I remember everything that I want to say, basically. So for me, wellbeing is all of the physical, social, emotional, spiritual aspects all wrapped in together. So it's an overarching concept. So how I sit in the world, how I relate to others, how I see myself, etc., etc. So it's not just a static or internal state of being. So there are many interdependencies, because none of us exist in a vacuum, really. So it's me in relation to others. And because, I'm a historian somewhere in my background as well, and our history and our social environment is part of the worldview lens that I sort of make meaning from. That for me, it's the history fundamentally that shapes the present sense of well-being for me. So I always reflect to the past, to look to the present, to the future, etc. So the social determinants fit in here in my ideas around well-being. It's fundamental to shaping well-being. And as you know, as we all know, those things can be historically driven, culturally determined through policy and power. Again, the history, the sociology, these are the things that influence me. So for things like power in relation to wellbeing, it's, you know, who has it, who doesn't, why, how they get it, how others lose it, etc., etc. So they become core to my understanding of wellbeing, particularly in how you prevent problems, how you grow wellbeing, etc. Those things have to be addressed. And mental health sort of sits within that somewhere for me. So it's a bit like, if I was to use an analogy, wellbeing is like the body and mental health is like the heart. That holds, so the body holds the heart. It's part of, one is part of the other. That's just my analogy. So as humans, the heart's pumping to keep the body going, but there's an interdependency. Both are interconnected somehow and they're vital to each other. So perhaps, you know, there's some similarities perhaps with the Indigenous sense of mental health and wellbeing. My bias since I was a small child was, you know, looking out onto the world from an internal self. So, you know, being mindful, reflective, thinking about things, taking in experiences from the natural environment, from the social world, and making meaning from them. So you know, perhaps I've conflated the two. I can't separate them. And some of that bias comes from my consumer advocacy as well, where mental health gets caught up in being a bit diagnostic, and actually people conflate mental health and mental illness for me, when they talk about mental health, but actually they're often talking about mental illness, and that's a conflation. So similar to the heart for mental health, I can relate to the narratives that see it not merely as an object or an organ in a diagnostic clinical sort of worldview, but something much more is going on for me in mental health. Just like in the field of heart health, for example, and that's why I'm using this analogy, how we think about it. So doctors can't explain brokenheartedness, the concept of having a heart. We all talk about that. And for me, when I talk about mental health, I'm not talking about a diagnosis, a diagnostic process. It's speaking to something much more for me as human beings, something to do with our soul, perhaps. So it's not just an organ performing a physiological function. So it's not the brain, mental health causing a functions. There's something more, something bigger, hopefully, going on, and something more central and connected. So, you know, that mantra of no well-being without mental health would be my adaptation of no health without mental health. So it's more about personhood for me, and clearly the mental health consumer advocacy area, that's what people are striving for, to say, you know, I might have a mental illness, but there's something else that you have to understand about my mental health. So if I was to continue the analogy, there are interdependencies between the two concepts. So the body can be well, but the heart may be struggling, just as Matt was saying, or vice versa. The status of one doesn't guarantee the same status of the other, but they need each other, and they're connected ultimately in the long-term picture of both of them. So that's probably a bit of a start.
Thank you so much for that, Sharon. And look, I think what you've done there is really drawn upon what Matt has indicated as well, but used a really lovely analogy between head and heart, which I think, you know, in terms of that. So thank you so much. I'm going to hand now over to David, who's just going to draw upon some conversations and ask some questions back to the panel members. So I won't share the slide unless you're wanting me to do that, David.
No, that's okay, Ivan. Look, we've had some comments coming in really acknowledging that there does appear to be a conflation between these two concepts of mental health and wellbeing. Now, obviously, Matt's talked from the work of Corey Keyes on how the evidence really leads to believe that well-being and mental illness are related but separate concepts. And then Sharon's gone on to bring in a range of ideas around really how there are other metaphors and other symbolisms that we can use to think about the relationship. And most importantly, I think also introducing the important role of social determinants, the cultural, historical, socioeconomic conditions that really do affect our well-being and mental health. So I think in terms of turning this into a particular question, I wonder whether or not we could have a response from both Sharon and Matt about that particular issue of, well, how do you see that these two concepts of mental health and well-being, when they are conflated, what are the implications of the conflation between these two terms?
Maybe, you know, the advocate in me would hope for a world one day where there weren't the two terms, where we understood that we were talking about one thing, and that there wasn't, you know, this expertise that's populated the area of mental health, which largely treats the person as the object. Yeah. So that's my start. Matt?
Oh, for me, it's the conflation is that mental illness dominates the conversation. That's what it means, because, you know, it frustrates me to no end when you turn on, you know, you open the paper or you watch Fox Footy or something like that, and they say this guy can't play because he's got mental health. And it's like, actually, what you're talking about is being diagnosed with a mental illness, and that's totally separate to the things that build his mental health. And so it just gets left out of the conversation. I think that's my big issue with it. In a lot of the ways that something like nutrition, you know, proper nutrition, some preventative strategies like nutrition have been left out of, you know, our medical system. It's the same sort of idea, which means there are a lot of illnesses that could have been prevented if we were focusing on, you know, proper diets.
Okay, thanks very much. I think back to you, Ivan.
All right, thank you so much for that. So I'm going to reshare a screen just to give us some key messages, and then we're going to take this a little bit further into the next stage of the conversation. So I'll come back. So we've heard from both Matthew as well as Sharon, and we've answered these questions. So here's some key themes for people to take away. I think we do need to differentiate wellbeing and mental health, and wellbeing promotion and mental health prevention. So what we are really saying is, across your communities, bring high awareness to these words across your sectors, and really, what does it mean? And think about, are we conflating terms? Really valuing in your community the different constructions of wellbeing and mental health, but in particular wellbeing, but work towards a shared community understanding. So definitely across a number of communities that LBI supports, we really encourage people to share their view of wellbeing, but find a collective term which they can talk to. That still allows people to hold on to their own construction of it, but works towards a shared understanding that you can work with either a care team, or you can work within a broader agency around. So we're now going to move forward to the notion of lived experience. So this is the next section we're going to talk to, and we're going to work through the same process as before. So we're going to think about the role of lived experience, and what I would say to each and every one of you, as a psychologist, the notion of lived experience really wasn't valued in my professional training. So I sort of sat on that right-hand piece there, professional expertise. As a psychologist, that was really valued, your expertise. And the notion of lived experience, the experience of the individual who had mental health issues, etc., that wasn't really empowered in the conversation of how we work together. So definitely what we're going to say here is we want us to think about the role of people who have lived experience, the role in helping us navigate both wellbeing and mental health. And what we can see is we need to bring these together in a co-production based way. So what are we going to do now is a quick poll to get your sense of how your communities think about lived experience. Lived experiences are the experiences of people in your community who have had mental illness, etc. And those experiences are valued in the communication. So I'm going to share this now. So we'll have a poll. So this is 2 questions, and they're fairly quick questions to have. Myself or someone I live with now has lived experience of a mental illness, yes or no? And how well does my community, agency, town, care team, school value lived experiences in understanding and making sense of mental illness? So we're going to really get your feedback on this and probably give you another 20 seconds or so to provide that feedback. All right, so getting close to 70%. If we can see, we can get up to 80 or so percent. Another 5, 4, 3, 2, 1. All right. So I'm going to share the results. So what we're saying here within our group, and you know, a very high percentage of the group, either themselves or the people they support, have a mental illness. And I would have, you know, ticked yes for that box as well. How well does my community value lived experiences and making sense of mental illness? Somewhat is the highest one. And I would definitely say across the work that we do in LBI, I'd say it definitely fits within that somewhat to not at all category. So I'm really looking forward to this current conversation to think about how do we uplift and value lived experience in the conversation around mental health and wellbeing. All right, so I'm going to now share my screen and allow David to give us a question for us to consider in the background.
Thanks, Ivan. So look, this is the very issue that we want to get to, and it was fantastic through that poll to really acknowledge that there are so many people who work in this space of building mental health and wellbeing who come to that from a position of lived experience and real insight. Of course, it's no surprise to many of us too that maybe that doesn't have the opportunity to be fully utilised within the communities and the work situations that we find ourselves in. So I guess the 2 questions that we really want you to think about and share your thoughts with us through the chat room, please, is how and why this lived experience is respected within your community. And most importantly, I think, how do we elevate the role of people with lived experience in both supporting recovery and building wellbeing? Thanks, Ivan.
Excellent. Thank you so much, David. I'm now going to hand over to Professor Sharon Lawn, who's going to explore that content for us.
A natural progression. Thank you. So what I said earlier, given that, you know, lived experience is a natural progression of the processes and ways of responding to the issues of wellbeing and mental health. It's about seeing lived experience knowledge and expertise being as valid as other forms of knowledge. So it's a type of knowledge for me because it's lived in the world, it's real, and it's centrally relevant knowledge about experience and meaning. So the things that I was trying to convey. So for me, it's also, you know, it comes from a justice and human rights perspective, which also are my biases, that respects the person's central placement in any dialogue about what's said about them and what's done to them. So, you know, lived experience has that real activism for me. And I don't mean placing the person at the centre. You know, there's a lot of focus on consumer-centred care, for example, and that frustrates me because that often then, you know, what happens with that is the person becomes the object at the centre. so the object for other people's actions, and that's not what I mean. I mean lived experience as an equal participant in any processes. I'm very conscious that many of the health systems and the structures in particular have developed knowledge. They construct knowledge in a way that it's a professional expertise, and that various disciplines, they've colonised and dominated what's perceived as evidence and knowledge. So they love giving people information. Health promotion, for example, is heavily about giving people information, and information on, it's good, it improves health literacy, but it's not everything. So it's based on the assumption that people lack something, and that the evidence from science or from assumed professional knowledge or experience has all the answers somehow. But what if the evidence has gaps? So I can tell you I've seen many evidence-based guidelines that have been constructed by rooms full of clinicians, but with little or no contribution by people who've actually been experiencing the conditions. So you only see what you look for, and sometimes you only look with a particular lens, so a particular cultural lens, a discipline lens, political lens, or some other bias. So what if those randomised control trials, for example, had limits in what they actually asked people, or the interventions that they did to test what the evidence was? It's a bit like asking people receiving a mental health care, do you want option A or option B service? And then concluding that people prefer option B because you didn't see or ask what else might have been an option. Does that make sense? So, so you're starting to see that there's a huge missing opportunity, and meanwhile we continue to invest millions of dollars in certain approaches to the promotion of mental health and wellbeing, also without ever tackling the causes of the causes, as the public health people would say. So back to those social determinants. It's a system that gets stuck, and unfortunately the experts get stuck. They sometimes deflect and then label the person because they get stuck. So health literacy is a field, it's a classic example of that process where we continue to give people good advice as somehow the holders of knowledge without ever changing the way that we deliver the advice or what we deliver, or checking if it matches what people actually need and want, or even what's feasible for them to take action to take on that information. So that's where lived experience comes in, absolutely, because it either directly from the person or the particular group involved, or from advocates whose role it is to be the voice for people who can't always speak in a room where their voice is silenced. So it's about sometimes only, people see themselves and their structures, their rules, their processes, their procedures, and they get stuck in that. So lived experience is such an opportunity to get things right, to save time, to save effort and resources, to get the outcomes that everyone's aspiring to, and which they continue to state are the goals for the populations that they serve. And of course, lived experience used in a way becomes even more important when we're talking about mental health and wellbeing, particularly when there are lots of people who are quite marginalised and disadvantaged and just in actually bringing their lived experience voice. So that's a bit of a snapshot of where I see lived experience.
Thank you so much, Sharon, for that one. So I'm now going to hear from Matthew. So you've brought a really organic conversation piece, Sharon, to that discussion around lived experience. I now hand over to Matthew to offer his insights.
Thank you. And just Sharon, just incredible. What more could anyone ask from a mental health commissioner to bring that perspective to the field? That's really, really, and nice to see how, I guess it's evoked a lot of responses in the chat as well, which means you really hit the nail on the head. what I wanted to talk about when it comes to lived experience was the difference between what we've called before clinical recovery and personal recovery. So clinical recovery is essentially, I think, a little bit like where Sharon was going, is that a clinician or a professional has diagnosed you with a mental illness, and then at some time later has said, actually, now you no longer have that illness, you've recovered by our standards. But what's been really interesting in the research land is that the integration of lived experience and clinical recovery have really come together and resulted in this thing called personal recovery. And of course, lived experience being about valuing the insights of people with a lived experience and their families and carers to improve services to best respond to the mental health needs to those clients. And essentially what's happened is when they've interviewed the lived experience of people with a diagnosis of a mental illness, and they've essentially asked the question that Sharon was asking there: what is it that you want? What are the things that you want from a mental health service to help give you the best quality of life? And the really incredible thing is that not much of it was about their symptoms. It was about these other things that you can see on the screen. And a lot of them speak to well-being rather than their symptoms. So the themes that really come up, and there's a really great framework, which is here on the screen, called CHIME, which has got a really great evidence base behind it. It's got lived experience absolutely at its core. And it's made up of the themes that have come from interviews from people around the world, generally in the Western world, of course. But and these are the things that come up. So connectedness, hope and optimism, building a sense of identity, finding meaning, and being empowered. And I guess the first question to ask is, do people who interact with our healthcare system as it currently stands, do they feel like they're building all of these things? And of course, there might be some fields where they do, and there might be some where they don't so much. And this has brought this idea of personal recovery. So personal recovery is about establishing a fulfilling and meaningful life and a positive sense of identity founded on hopefulness and self-determination. So this is about feeling well with or without the diagnosis of a mental illness. And for me, this is a really great example of the inclusion of well-being into the mental health care system. So back to you, Ivan.
Thank you so much, Matt. And we've had some whole range of views which have come up in the group chat. So I'm going to hand over to David now to bring some of them to the fore.
Thanks very much, Ivan. So yeah, look, clearly the whole notion of lived experience really resonates with the audience. So really, Sharon highlighted the missed opportunity that we go through if we're not including the insights and the experience and the knowledge and the wisdom of people with lived experience. And Matt really talked about how the whole recovery narrative is founded on embedding ideas around wellbeing within it. Having said that, we've had some responses from people who are reflecting a couple of other ideas as well. The notion of lived experience extending to families and carers being a really important part of that. And Leanne commenting on the fact that quite often that's at considerable cost to families and carers as well. But we do that because that's what families and caring is about. We've had a couple of comments about the whole notion of stigma and shame that still accompanies mental illness, and how at every level in our society, notwithstanding the great improvements that have been made, that stigma and that shame is still there. And that brought up another comment, I think, in terms of how still in the clinical world, there are too many strategies, too many practitioners who want to go straight to fixing problems rather than seeing and listening and understanding the person involved. And finally, to Michael, thanks very much for sharing that information about another resource that's available, and also to others who have highlighted some of the great things that are happening in some sectors around embracing the lived experience of people with mental health challenges, particularly in disability and psychosocial care. So that's probably it. And I think it takes us right back to the question then to both of you. I put to Matt and to Sharon, if there was one thing that you could do to really elevate the the role and the perspective of people with lived experience in the broader mental health system, what would that be?
Okay. Do you want me to go first, Matt?
Yeah, please.
Yeah. So,
Tough question.
You know, I don't think I'm alone in thinking, but for me, you know, I've had mental PTSD stuff for a long time, and you know, I'm a carer, and this is my world, and I live with this, you know. So for me, it's a strength, you know, and I live. At the end of my life, I'll look back and reflect and think, I was glad, not for all the traumas and the things, but it's a strength. You know, lived experience is a strength, would be my thing. So, you know, I'm fortunate that I can, you know, I don't feel the stigma, and I'm not going to take it on anyway from people. That's their issue if they want to do that. But it's such an asset, it's a strength, and you know, I'll look back and think, yeah, that was something that made me see things with greater clarity. It made me work out my priorities in life much clearer. Maybe I've always been that way. But yeah, it's a strength and an asset.
Yeah, and for me, I would say it was a very good question, David. So let me just see how I go with this answer. But for me, it's about, if I could change one thing, it would be to change the over-reliance on our diagnostic systems. Because at the moment, people are diagnosed with a mental illness, and that takes away a lot of their agency, I think, the way that it rolls out. And I don't mean that it's done in a cynical way, but I saw some really interesting research the other day that someone who's lost the loss of a sense of control over your life is almost the same as losing your job, on the effect that it has on your mental health. And so I think that when someone's diagnosed with a mental illness, they're not given too many options about what they could actually do to help themselves, or that their friends and family could do to help them. And that's why when you look at that sort of personal recovery model, I think that actually does give agency back to the individual, which is in line, I think, with what Sharon was saying. So, you know, building connection, building meaning, identity, and purpose. These are the things that people can do with their family members and with the people around them in their community, which can ultimately help them recover or manage with their mental illness.
Back to you, Ivan. Thanks very much to both of you for those responses.
Yeah, thank you so much, everyone, for being a part of that conversation, and really the you know, the vulnerability everyone sort of showed in that space too. So, and thank you so much, Sharon, for those insights. I'm going to work to summarising some key themes, and also going to draw upon a question which was named to myself here, and around lived experience versus living experiences. And I do want to draw this down a little bit into some of the areas that LBI does support and work within. So a key take-home message here is that we do need to empower the voice of lived experience that promotes well-being and mental health in communities for all. A key point that I would raise, though, is that having lived experience, as Sharon has indicated, is a great strength. But we do need people who support vulnerable community members if they are living their experience of mental health, meaning they're really active in symptoms. They do need to bring high levels of awareness to what's happening to them, because especially very vulnerable community members, meaning, you know, children of trauma-based backgrounds, if they are experiencing caregivers who are very erratic through their experiences, that can have a negative developmental impact. So lived experiences are really important, but we do need to bring high awareness if we're living our experience of well-being, that it doesn't have an unintended impact. That's not to say that if you're a caregiver who has depression, anxiety, or even any diagnosis, that you can't care for children who are got trauma backgrounds, but it does mean that you need to bring much high awareness to what's happening for you and what's happening for the child in that situation. And this is really the take-home message. Everyone has lived experiences. And I think that's how we would frame this as well. Everyone has lived experiences of mental health and well-being. That doesn't mean that you have a lived experience of mental illness, but we need to value our experiences as human beings around well-being. all of us have a lived experience of this to some degree. All right, and finally, we really want to integrate the evidence of the wellbeing science with the experience of community members. So what we're really saying in LBI is that let's draw upon some of the key evidence-based approaches that we're going to hear today and we're going to focus on, but let's draw that into your experiences too, and make sure that your wisdom or your lived experiences supports the way that information is applied and used. All right, we're now going to work on to our next topic, which is around risk groups, and then we're going to work towards preventative strategies, etc. So we're going to think about who are the existing emergent vulnerable community members, and we're going to really bring a lens to who is vulnerable. And I guess, you know, there's no black and white answers here, but we're really going to be thinking about the lens of vulnerability. And in this conversation, we're going to ask you to think about these points. And I'll introduce now David to get us to think about these key questions.
So I guess there's 2 points to the way we want you to think about this. I guess, once again, for those of you who have been involved with the intentional practice methodology, the notion of context is so important here. So we do want you to reflect on the contextual factors that you would want to be keeping in mind as you think about the vulnerable communities that you might be engaged with. And also particularly as we reflect on the impact of the COVID pandemic, how are you seeing that the challenges faced by vulnerable communities have really been amplified as a result of COVID? So once again, we ask you to keep this front of mind as you listen to Sharon and to Matt. And once again, we encourage this really rich engagement that we're seeing through the chat room. So thanks very much, and back to you, Ivan.
All right, thank you, David. So we're going to engage you a quick poll just to get some of your insights, and here's an opportunity for people to be part of the conversation. I'm going to launch the polling now. And this is the questionnaire. As SA moves out of active COVID-19, what are you noticing within your community in terms of wellbeing? So are you noticing increased levels of community wellbeing, no changes, or a deterioration? So getting you to think about what you're noticing within your community, which could be your care team, your school, your agency, etc. And as South Australia moves out of an active phase, what are you noticing within your community in terms of mental health and wellbeing? We're starting to drill it down into more what we see. Are you noticing more anxiety, more depression, more loneliness, more people being lost? Are you observing more reactivity? But are you also noticing more family connections being valued, stronger community connections, people having more life satisfaction, a stronger connection to their values, or more optimism? So we want you to bring a lens to thinking about what are you noticing within your community, but both looking at that from a sort of well-being lens, but also some mental health or illness type lens as well. All right, so we're up to 30% of the vote. So we're looking forward to hopefully get to around 85%. We'll get people to track towards that, give you another 15 to 20 seconds. And then we'll allow people to see what the collective group is thinking about in their communities. All right, so I'll give you another 10 seconds. We're up to nearly 70. All right. So 5, 4, 3, 2, 1. All right, we've just ticked over 80%, which is good. I'll stop that now. So what are people seeing across their community? So there's, all right, there is a bit of a mixed bag there. So there's for some areas, a deterioration overall, 39%, but other people are seeing a sort of increased level of community wellbeing. What are we seeing in terms of, you know, the profile of experiences? And definitely we are noticing that people in their communities, there's a high level of generalised anxiety and stress. And I think that's a fairly common feature. And I could definitely say my experiences, you know, that's something I'm noticing as well. But we're also seeing that really well-being focused around family connections being valued. Community is also connecting, and people are starting to connect to their own values, what's important to them. So I think it's nice for us to look at that, even though COVID-19 has put a lot of stress in our community, and maybe it's lead to increased stress and anxiety. There's also some positive features which come out of this too. All right, I'm going to stop the share of the results here. What I'm going to do now is just to give you some really quick slides around the prevalence of mental health and wellbeing, or mental health within children and adolescent communities, and then we're going to hand over to our panel. All right, so I'm just going to bring our lens to the child and youth lens and give people some really key statistics. And this is drawn from the most recent research which has been done. So if we look across children and adolescents, and the left-hand side is young people in years 1 to 6, and the one on the right-hand side is 7 to 12. Now we can see that for children in years 6 to 11 years of age, 18% of males and 12% of females are diagnosed with a mental disorder or meet that threshold. We can see that that actually reduces down slightly in time. So when we get to the slightly older cohorts, the adolescent cohort, that frequency does go down. However, what we can see is that depression goes up as we start looking at adolescence, and anxiety disorders start moving in a backward direction. So let's go to another layer here. And this is a really important one, which thinks about depression, which is obviously really deep sadness, etc. What we can see is over the adolescence is that the rates of depression, in particular for females, really skyrocket. So 11 to 15, 7.2% of females meet the criteria for a depression disorder. And by the time they hit 16, 17, nearly 20% of the population group. And that's definitely magnified for females more than males. If we think about self-harm, and this is again often self-harm is linked to depression, we can see that that same sort of rate is shown for males versus females across these years. And interesting enough that 16% of females 16 to 17 have self-harm in the previous 12 months, which is a very high percentage. If we look at suicidal behaviour, and again, we look at ideation, which is thought processes, suicide planning, which is a plan moving forward, and attempt is an active process, we can see that suicidal ideation, planning and attempts generally increase from 12 to 16 years of age. But again, we see this is more magnified in females more than males. And a final, who are the young people who are most at risk? And context is key here. And this is from research, and we know it's those key social determinants. Blended one-parent families, low household income, periods of low education, and high unemployment. These are some key risk factors for mental illness. And if we look at it more broadly, and those in our group who come from a child protection background, we know that risk factors would include trauma, living away from home, those unstable early attachments. And quite interesting enough, living outside of a capital city for young people. But this is more so for males and females. So rates of mental illness increase in a metropolitan city from 12% to 16.2% if you're living away from a capital city in a regional area, but more magnified for males. All right, so I'm now going to hand over to Matthew, who's going to give us a little bit more context around these risk factors from his perspective.
Thank you, Ivan, once again. Just go back to the slides real quick. So when we talk about vulnerable communities, what am I doing? There are some different ways of thinking about vulnerable communities, and I know there are a few that Ivan has raised there, but this is one. Can everyone see my slides? I just can't. I hope so. This is one that we might not have thought about before. So when we think about this dual continuum model of mental health, you remember the 4 cartoon characters that I showed you, you can sort of break up a population to see what you see in terms of who sits where. And in particular, we know that, so this is some of the data that we've collected from South Australia, where we see that there are a lot of different people in these different groups. But in particular, we think about this vulnerable group here.
Sorry, Matt, just quickly to let you know that your slides aren't being seen. So you might.
Oh, they're not. Oh, what happened there? Sorry, thanks. Sorry, guys. Oh, okay. Forgot to click share. That would do the trick. Sorry. Thanks, Ivan. So starting again, here we go. Here's what I was talking about. Hopefully it makes a little bit more sense now. You see these different percentages of people. This is in the South Australian context, just from the data that we've collected over the years. And in particular, we've got this little ninja emoji, which is the vulnerable group who we consider are the invisible people. I mean, this is a slightly abstract way of talking about vulnerable groups, because it's not one particular group in terms of a cold community or a disadvantaged community. But these are people who, like I said, wouldn't be diagnosed with a mental illness, but they have a low level of well-being. And there's quite a large proportion of them in our society, as we estimate to be almost 30%. We know that when we look at these different groups of people in schools, you see that young people who have high levels of well-being without a diagnosed mental illness perform better in a range of outcomes. But most importantly, it's the case that just because you're diagnosed with a mental illness doesn't mean that you can't get really high levels of these things, but it's also that focus of well-being as well. But the reason why I bring up that low well-being group as a risk factor group is that we've seen in the evidence that that when we look on the right side of this table, when we look under the heading of prevention, we see that people who have a low level of well-being or whose well-being reduces are massively at a higher risk of developing a mental illness in the future. Something in the order of 7 to 8 times more likely to have been diagnosed with a mental illness. And the same is true. The opposite is true as well. So those who can improve their level of well-being are actually protected from developing that mental illness. And we know from a research, but also from a system perspective, that identifying risk can be really useful for targeting our prevention and our interventions. And why I bring this up, this low well-being group, is that we know from our evidence, we actually had a paper published on this recently, but from around the world, we're seeing that well-being, of course, has been massively impacted as a result of lockdown and coronavirus. So, of course, there are many reasons why this might be the case, from the loss of personal agency and autonomy, the lack of physical activity from the closure of gyms, sporting clubs, parks, recreational areas, the impacts on spirituality and interpersonal relationships, churches and places of worship being closed, restaurants, bars, universities, schools, and the impact on purpose and meaning of life from financial distress or loss of employment, or significant lifestyle changes that we've had to see, such as managing kids at home, social isolation, and loneliness, which all of these things I saw came up in the poll as well. So what I'm sort of trying to say here, I guess, is that we know that the loss of well-being is a really big risk factor for the development of a mental illness in the future. And we know that it's very likely that many people in South Australia will have lost a level of well-being as a result of the coronavirus. So rather than sort of focusing on a particular group, I wanted to think about it in this perspective, because the interesting thing about the impact of coronavirus is that I think it's affected people very differently. I still have managed to have my job. My next door neighbor has lost his job merely for the fact of the industry that he happened to be in, that's an industry that's been affected by coronavirus more than mine has. So I think thinking about it as groups of people is one way of doing it, but this is another way as well, which I think is that invisible thing at the moment, because we don't focus on well-being so much. Thanks. And sorry about the slide sharing there for a bit.
Hand over now to Sharon.
Okay, thanks, Ivan and Matt. So, it's a case of where do you start? As Matt suggested, it's not like there are so many groups in the community that have particular needs, particularly for strong advocacy and support to ensure mental health and wellbeing. So, I'm particularly concerned for young people, as you've already flagged, Ivan. Certainly we're told about the pending, the issues around finding employment as people are leaving school, and in the next year or two, what the employment prospects will be like. Certainly the recent reports from the Children's Commissioner are really interesting in relation to that transition from education to work. So I recommend people get on their website and have a look at some of the reports, and also a lovely report they did around young people in rural South Australia. It's, you know, it was certainly a sobering reminder for me that how vulnerable young people are to the decisions of adults. You know, they don't get to vote, they don't get to support how the policies are made or determine the priorities. They're very dependent on other people making those decisions, and a lot of this control and power of what's happened during COVID has been taken out of their hands, really. So it's such an important time in people's lives, so much to deal with, particularly during adolescence, and the figures that you've shown really do say that there's something really significant going on, and we know that a lot of mental illness develops during that time. I remember my own adolescence, you know, often, you know, it's a really tumultuous time, becoming oneself, becoming an adult. So many unknowns, uncertainties about the future. My father often would say, you know, you've just got to hold your breath and hang on and hope for the least amount of damage through that time, really. So, of course, so young people would be, you know, if I had to pick. But also my other bias is obviously, you know, people with severe and enduring mental illness during this time. For a range of reasons. So there are some groups that always seem to be on the margins, often because of social stigma, and they seem to be on the outer, somehow external to the main sort of dialogue that's going on. Someone, you know, we've had a real reality check with COVID. It's making people reflect and think about the meaning of things a little bit more than they might have, and some for the first time in a stronger way, thinking about well-being. So, you know, people who live with social isolation and marginalisation and having to go without could perhaps teach others, and a few people have raised that idea that, you know, some people weren't feeling affected because this is their reality anyway. Other people were. So I also worry about what will happen after this period is over, when, you know, will we keep the lessons that we've learned about thinking, you know, will we sustain some of that thinking about well-being, about reprioritising, you know, will homeless people leave the hotels and just go back to being homeless? What will we all do about that? What will happen to improve the life of people with disabilities, and psychosocial disabilities, people living in SRFs, for example, who yeah, they're not really being considered during this time other than being contained, so that others are not at risk, perhaps. So it's not a simple case for me of identifying who has the most needs and somehow prioritising groups as if it's a competition to argue whose needs are more pressing or more important or more worthy, or, you know, that's fraught going down that path. It's just, you know, what happens then is you just get whoever speaks the loudest, whoever has the loudest voice, who has access to resources to influence the argument for who gets what. And, you know, it all gets a bit political. So a good place to start, where you put this question to me, and I thought a good place to start to think about where to start is perhaps to focus on individuals who actually belong to more than one marginalised group, and who may therefore experience multiple disadvantaged. So without wishing to stereotype, you know, the person who is marginalised by their race or culture, poor mental health status, gender diversity, low access because of their location, literacy, who've had significant experiences of trauma or abuse, they're likely to be facing far more need and be more vulnerable, perhaps. They may be, you know, holding on in strength, I don't know, but they have so much to deal with. So that would be something I would consider. So ultimately, it's not about thinking about purely as individuals who define, you know, and how we define them as vulnerable, as if it's somehow, you know, this internal thing. What most likely makes them vulnerable for me is much more about the context in which they sit. So the social relations, as we talked about earlier. So how groups are positioned in relation to access to employment, to resources. Maybe thinking about that, you know, yeah. So the issues of structural stigma and racism and discrimination that may be at play for different groups. So the challenge is to navigate the ways of responding that don't inadvertently perpetuate stereotypes either, and perpetuate stigma for particular groups. Because what can tend to happen is we all get so busy in attempting to address this and do prevention, and all we do is objectify people, and we stigmatise them even more by labelling. So I'll probably leave it there. So it has to be done in a considered way, thinking about vulnerability and who's vulnerable and how we actually do that. And we've talked about lived experience and how that connects in. You know, that's a way of ensuring that people are not objectified and labelled, because we're actually truly sitting down together in a room together. Okay, thank you.
Thank you so much, Sharon, for that. And I'm going to hand over to David. I'm really keen, Dave, for you just to really bring some summary comments to it. We may not have time at this moment to go back to the panel in terms of some questions. So.
Yeah, no, look, I agree with you, Ivan. Look, some really diverse and rich commentary that came out of that. Firstly, from Leanne, some general observations about, I suspect, a regional context and the challenge for people dealing with COVID moving from in-person to online strategies, and the fact that services were closed down and how difficult that was as well. Also, some comments around the challenges for CALD communities, particularly when there were concerns about what might be happening for family back in other places, not in Australia. I think the comment that came out most generally here was, look, this has affected people differently, and we just need to accept that. But there was, as both Matt and Sharon in particular really highlighted, some groups that experienced really increased levels of marginalisation as a result of the COVID experience. And another comment that came up that I'd like to explore with the group is that, yes, there are groups that are marginalised, we know that. Probably the impact of COVID more generally was to amplify their experience of marginalisation. But as the speaker, and I think it was Joshua who made this point, and of course it's always white, middle-class, middle-aged men who are primarily driving the decision-making around how we strategize around this. So I think that's a white, middle-aged man. I absolutely buy that analysis. And so I think one of the questions that I'd like to put to the group is, well, as we do extract the silver linings from COVID, how is it that we can develop conversations in our communities that are about engaging a broader range of voices in how we move forward and how we attend to some of the challenges that we as communities face, but that certain groups within our communities, for all sorts of different reasons that both our speakers have mentioned, are most likely to impact on them. So I leave that as a question. Maybe we can take it up at the very end, and I think straight back to you, Ivan.
All right, thank you so much, David, for that. And look, we've got two more topics that we really want to cover today, which is around strategies, but also hearing from Sharon around strategic direction. So we've got about 20 minutes each to do those. So we're going to keep pushing forward. I'm just going to share the screen just to allow us to talk through these topics. And I just want to summarize this last point around what we've just covered. We looked at risk factors. Vulnerability is not something that can be reduced down to singular factors. It's complex. We need to look at the interaction between individual and their context, circumstances, etc. And we really need to look at COVID-19 vulnerability through the lens of it is unprecedented, and I hate to use that word, but to acknowledge that we need to keep learning in this new environment. And it's really great to hear what Matt said is a key lens that we can look at is around risk, around wellbeing levels. All right, so we're now going to look at those best practice strategies to move forward, and we're really thinking about, you know, how do we consider strategies in the context of existing and emergent communities. And I guess a key slide to bring to, you know, I sort of draw upon David, who introduced me to this concept, this sense of, you know, we find that many of us end up falling into the river where we feel like we're drowning sometimes in terms of how we're feeling about life. And there's two key things here. How do we actually stop ourselves or others fall into the river? But when we do, how do we actually pull ourselves out of that? So we're looking at both prevention, but also responding to the situation. And I'll get David to get us to think about these questions as we hear from our speakers.
Thanks, Ivan. So look, there are just a couple of really practical things that we want you to put your mind to here. If you as our participants in this webinar can think about the two things that you've seen in your experience, whether that's at a community level, in your family, in your work, that have been most effective in terms of preventing poor mental health generally. And I guess the two things that you've seen the most effective in promoting wellbeing. So if you could really think about those two questions, that would be fabulous. Thank you.
Oops. All right, so now we're going to hear from Matthew, who's going to shine a lens on this topic.
I'll remember to click share this time. Okay, great. So basically, I use this slide just to say that when it comes to prevention, what we really find is that if you say to somebody, you know, how do you prevent obesity? People know the answer, you know, or, you know, they know one answer at least, you know, exercise. How do you prevent skin cancer, sunscreen, lung cancer, quit smoking, drowning, swimming lessons. But when you say to somebody, how do you improve your mental well-being? They don't necessarily have the answer. And that's why discussions like this are really, really important. We know from the evidence that there are lots of ways to build mental well-being, exposure to nature, spirituality, connection with others, physical exercise, things like mindfulness, meditation, and policy as well that can influence the well-being of people in a society. In particular, we focus, our lens is through psychological programs and little habits or activities that you can build in your own life. And we did a lot of work at SAHMRI focusing on understanding what are the most effective ways to build your level of well-being from psychological interventions. But most importantly, what we wanted to understand was what is the impact that some of these interventions have, not only on well-being, but on indicators of depression, anxiety, and stress. And so as you can see here, I won't go into the detail, but we found a range of different interventions that have a differential effect on these different outcomes. And what we really want to use this is to understand, well, if you wanted to work on one of these outcomes, what would be the most effective intervention to use? This is the more sophisticated version of it, I guess. This is what it looks like from the science perspective. The only thing I wanted to show you here was that we looked at it both in the, you know, which interventions are effective in the general population, which are effective in the mental ill populations, and in physically ill populations. And of course, what we saw was different interventions work for different people. But mostly what we wanted to highlight here is that it is possible to build well-being in those with a mental or a physical illness. I'll just click through this, sorry. Basically, the ones that came across as the most effective, just to sort of go straight to the spoiler, was mindfulness. And I know that that's really at the center of intentional practice and intentionality. And the reason why I was very pleased to see that result is that we know that there are lots of different ways to practice mindfulness, which means you can contextualize it to your own lifestyle or to the life or the context of the people that you work with. There are some really great resources from the Berkeley Greater Good Center, which is on the slide now. I can send these links in the chat if you'd like. Also from positivepsychology.com and from our own website at SAHMRI, the BeWellPlan.com, which really have a list of very effective variations of how you can practice some of these things. The one big take-home message for us that we found from this research was that while there are a lot of effective ways to build well-being, some of them are on the screen here, but I'd encourage you to have a look at these websites. It comes down to how much you practice it. And once again, going to that physical health example, going to the gym once is okay, but it doesn't make, it doesn't equal instant weight loss. So it's about repetitive dedication to building these things in your own life. So thank you.
Thank you, Matt, for that. And I'll hand over to Sharon.
Yeah, thanks, Ivan and Matt. So the biggest thing for me is actually, Matt's described the internal and the psychological. So I'll do the other. It's mobilising the communities from within for me. They're good ways to start around prevention. By this, I mean giving communities as much control as possible of decisions that impact the members of the community and build their capacity to be self-determining. I think that the external will impact the internal, if that makes sense. So, it's a strength and assets approach that works to mobilise the naturally occurring and existing peer support networks that exist. And, I grew up in a country town, so I know how that can work to build community. I think those things are significant. And that has to start with going to people, going to them to ask them about what solutions are at hand to solve the issues that they have, and their capacity to identify what they need and what form that will take, to listen to them, if that makes sense. So rather than imposing solutions from outside on people. So speaking less and listening more would be the thing there. So taking the time and creating an environment in which people can actually express their views and preferences safely without discrimination, or finding a way that they can express them so we don't set the rules about how things are expressed. So the self-management area, which is an area of research that, for me, and self-care, is an interesting one because there's a logic to it. It's about the person's capacity to solve any new challenges as they come up into the future. So it's a focus on mobilising the person's abilities and capacities and assets so that they don't have to keep going back to someone else to fix something, so that they actually gain from that process themselves and then can take that as an asset forward. Otherwise, we just keep putting a Band-Aid on things. We keep doing things for people. So it's about building people's independence rather than dependence on others, because that's disempowering people if you do that. So, and it takes away people's dignity and self-respect. So all these things feed into all those things that Matt was talking about as well. So part of that is actually having trust that people actually can build capacity, can have capacity, and that you respect that they have that. Otherwise, they're just receiving experts' advice, and that's not what you want either. So I guess the other bias for me is, as a mental health worker for many years, I've seen how people can hurt each other and damage each other and the long-term consequences for people's lives. So all of those things that you mentioned and you put in the chat about attachment and how important that was. So, you know, doing things in a preventative way that help families so that there is less trauma, abuse, poverty, things like that in families and communities. You know, it's why we have the JobKeeper payment, because economic, financial stress and poverty are such important things for wellbeing and impact wellbeing. You know, drug use is another thing, and I won't go on about that. A world free of the damage of drugs would be wonderful. So coming back to the causes of the causes for me, and I'll leave it there. Thanks, Simon.
Thank you so much for that, Sharon, and giving us that really nuanced view there. I'm going to hand back over to David now, who's going to draw upon some of the key themes. Then I'm going to hand back to Sharon, who's going to really give us some key insights where the South Australia is heading in terms of wellbeing and mental health.
Thanks very much, Ivan. Look, once again, a really rich set of commentary that's still coming through, and I'll try and capture most of this as I can. But clearly what we had presented was two positions where we were talking about what can individuals do based on the evidence to improve their own personal wellbeing and mental health. And Matt shared with us some of the strategies the evidence is really clear about. And so that's really important. But there was also a really strong thread and strand that lots of people talked about in terms of what can we do as communities. And Sharon really picked up on that as well. So we've had this notion of how do we get back to, and I'm picking up on Erica's words here, to true grassroots community engagement, to enable communities to determine what is important for them and to develop their own responses to that. And that notion of empowering, building capacity at the community level, in some ways matches what also needs to happen for individuals as well. This is a process of empowerment, and it is a process. It's not an event. It's not a one-off thing for either individuals or communities. So we need to continue thinking about those. We have such a rich community within the LBI family. We've talked about this notion of both individual work and community-based work now for forums over 3 years. So it's my particular passion on how we work at the community level to build this work. And so I'm really vested in finding opportunities to explore more with members of this sort of forum to how we actually make practical steps to move in this regard. But look, one of the other things I want to mention was something that's come through from a number of commentators about the idea of reducing childhood trauma as being actually a pivotal step that we can work at. And I'm reminded of the success of a program called Together in the South that operated in Southern Adelaide a few years ago, where there was a focused attempt to reduce the likelihood of poor outcomes for children between 3 and 7 in 7 neighbourhoods within the city of Onkaparinga. Really fantastic program, ran out of funding, as is often the case, but I think those are the sorts of strategies that I think we should think about. So Ivan, I think let's crack on, hey?
Thank you so much, David. And look, I'm not going to share any slides because I think you've summarised this section really well. And I'm now going to hand over to Sharon, who's going to have a conversation around you know, where is South Australia really thinking about mental health and wellbeing? And what I'm going to do is just really encourage people right now to put some comments in the chat around any questions you have towards Sharon. So we're going to allow Sharon to have the floor for the next, you know, 5 or 6 minutes to really give us that direction. And then I'm going to have David, who's going to uplift those questions. So if you've got a question for Sharon, can you really put that into the group chat, and that'll be uplifted. So I'll hand over to you, Sharon.
Okay, sounds daunting. When I thought about this question, I really just came up with a list of what's currently happening, and obviously there are a range of things that I've, you know, in my commissioner role, and David would know as well. You know, we're seeing and we're being part of a range of initiatives and government responses to this process. So the first of those is COVID Virtual Support Network, which some people may or may not have. There's information about this virtual support network on the SA Health website. So essentially it's, you know, in response here, it's mobilised and expanded a number of existing, essentially, internet and telephone support lines. So Lifeline, Carers SA, Theoretically, the lived experience telephone support service. So all of those have received, and Relationships Australia for call populations, they've all been asked to mobilise up what they're doing, so that they're not only receiving calls from people that, because they know their communities already, so they're reaching out, so calling out, so people are not sitting at home, you know, struggling, particularly people who may not have access to technology. There's been a significant conversation there. So not just waiting for people to seek help, but actually actively reaching out to different communities, which has been a good thing. So that's the first one. And then another strategic area is obviously the establishment of Wellbeing SA, which is, it's a new organisation that sits next to and separate to SA Health as its own focus on the wellbeing of South Australians. So it captures 3 areas that were formerly part of SA Health. And for us, the Wellbeing, Mental Health and Wellbeing Directorate are particularly active as one of those 3. One is related to data, one is related to integration care systems, and one is related to mental health and wellbeing. And they're going to integrate and work together much more to have a stronger focus on wellbeing across the state. So their activity is very much lots and lots of public awareness raising, education, information, connection. They've got a fantastic website. I'm sure people have passed bus stops and seen Open My World on bus stops, and hopefully on wheelie bins soon in some areas. So lots and lots of great resources. Another aspect which has always been a focus is on suicide prevention. So there's been a lot of work supporting, mobilising the suicide prevention networks, which variously sit at different places around the state. So John Dawkins is leading up that work. He's the Premier's advisor on suicide prevention, and it's brought together a whole lot of stakeholders around this issue. And our co-commissioner, Heather Noack, is heavily involved in that. Another one I really would like to mention is the Faye Fuller Foundation, who are doing great work in the Our Town initiative. So it's such a great thing to see committed funding to supporting communities. That's not just, you know, a quick pilot, but it's a 10-year, up to 10-year commitment to support communities, just as we were saying before, to mobilise their own resources and identify what they need and act on that for wellbeing. There's all sorts of different things that you could add to this sort of list. You know, we have a state mental health services plan, which, you know, we've had many plans where, you know, we have great hopes and aspirations for many of the new initiatives in this plan as we go along. There'll be much more focus on lived experience. The operationalising of that is what we really need to get right, because the rhetoric and the reality have to actually match. So lived experience workforce is really, really a real effort to put that meaningfully and embed it into what happens in the next 5 years in South Australia's mental health services across NGOs and clinical services, etc. The SA Mental Health Strategic Plan, again, you know, that a lot of that work is picked up by the Wellbeing SA awareness raising information. Another interesting area that relates to the social determinants is people may or may not know that SA Health actually leads a WHO collaborating centre for the health in all policies, a lot of the health in all policies work, which addresses that issue of, you know, getting people that work in homelessness, that people that work in housing, that people that work in education, health, etc., all in the same room to talk about how they work together. So connecting up some of these areas rather than being separate floors in a bureaucratic system. And South Australia has been doing such great work in that they are now a WHO collaborating centre. The Adelaide Zero project was doing, you know, it's COVID has changed things obviously for that, but again, you know, that was about dedicated, committed stakeholders all getting together to try and fix this. So that's another aspect. And I'm sure that work, you know, there's more to do, obviously, in that area. Their focus was on addressing street homelessness particularly, but the idea of taking the learning from that and actually applying it to homelessness more broadly into the future. The other, you know, the thing I'd probably finish on is, you know, the priorities that we as mental health commissioners have set for ourselves. You know, there's it's a long list, and so we said, well, what are the key priorities, the things that we want to get going on sooner rather than later? And because of the imperatives of the plans that are in place, you know, we chose 6 ones particularly, but that doesn't mean that the work of other things doesn't happen as well. So the peer workforce was particularly the lived experience workforce, because plans are contingent on that being successful. We need to help facilitate to get that right. The suicide prevention work through the Premier's Advocate is another area. Mental health and homelessness is something that I know David and I are incredibly passionate about. Mental health and wellbeing in the workforce is another area that we're focused on, and David's doing a lot of groundwork in that area at the moment, connecting with people that are very, very much getting together to really get some momentum happening in that area. And broad community wellbeing. So we know that local councils, local government, community itself actually has a lot that it achieves here. So we're really keen to get involved in all those areas. So that's probably where I'd leave just my general description.
Thank you so much for that, Sharon. I'm just going to hand over to David if you wanted to uplift some comments in the chat and pose any questions back to Sharon in terms of what she just said.
Yeah, look, there's been a lot of comments that have come through, and Sharon's named a range of different policy strategies and initiatives that are really important to improving the mental health and wellbeing of South Australians. I think if there is one set of comments that might be turned into a question, it does have something to do possibly on this thread that's been prominent today about how we reduce the likelihood of trauma for children, and then how we introduce and normalise conversations about mental health and wellbeing for young children. So Sharon, I guess if there's a question, and I know this is putting you on the spot, but in your role as Mental Health Commissioner, how do you think we might go about trying to to introduce strategies and structures that would enable us to introduce and normalise conversations about mental health and wellbeing with children and young people in schools.
Yeah. I think, you know, whether it's our role, you know, clearly there are others like the Children's Commissioner who is very in the space. And I know, you know, Wellbeing is particularly the Mental Health and Wellbeing Directorate are doing some lovely work around getting people to read stories to children, putting that up online so that parents can show their children and children can view that. I think there's a lot more that could be done around resources for families. You know, there's so much out there on the web from Australia and everywhere else around, you know, how do you talk to children? How do you tell children about COVID and everything else? Yes, schools have so much that they have to do already with children and their well-being and the curriculum. Yeah, it's a hard one, David. I'm thinking of all the things that have to be done. You know, keeping normality. I know I was on the phone last night with a young adult who he was just so glad to get back to training and sport, and you know, there's so much. You know, it's not just one; it's everyone has a responsibility for how we actually respond and help children. I think in this. I'm not sure if I've answered your question at all.
No, that's absolutely fine, Sharon. It's a really tough question. I think it's one that, as much as anything, I think once again, building on the strengths of the LBI network to get us all to think about, well, what is it that we can do within our communities to start to bring greater focus to these sorts of conversations. Yeah. So Ivan, I think probably, given the time, we might hand back to you now.
All right, thank you, David. Well, remarkably, we're on time. I'm not sure he did that, but we've got towards the end point. And look, there's been some really useful conversations, and I might, you know, what we're going to do now is work towards a summary point of this, and we're going to allow each panel members to have about a minute or so to summarise some key messages or themes that they'd like to uplift in the conversation. And then we would love to do a final poll with people to get your feedback of today, because we're very much entrusted to your support and would love to know how we can do this better in the future as well. There's been some great conversations today, and I think all of us are learning, but really what's come through is that mental health and wellbeing is a complex conversation from my end anyway. It's we need to look at them through critical lens, you know, what words we're using, how we're applying them, but making sure that we don't lose sight of these words in our conversations. I'd also say there's some really great themes around, which has been introduced in the chat line of, you know, even words like infant mental health. You know, that's a word which is often, health departments will talk more about that, but those words aren't often heard in child protection or even educational settings. So I think it's around creating a language which we can create a more diverse view of mental health and wellbeing. And definitely from my, you know, the work that we do moving forward, the notion of lived experiences, you know, we might find terms that we can work with communities on. I think we want to uplift that. We want to empower the voice of lived experiences, but also that every human being has lived experiences around mental health and wellbeing, given we're human. So that's sort of my summary comments. I might throw to Matt to give your summary comments, and then we'll go to Sharon and David. You can finish it off. So.
Yeah, thanks, Ivan. I mean, the first comment to say it's been fantastic, especially to hear from the things that you guys have had to say, particularly Sharon. It's been really encouraging to see the direction that we're going as a state. We couldn't really ask for much more. But for me, the idea, I think what's come through for me really clearly is that a lot of people are responsible when it comes to mental health and well-being. There are lots of different stakeholders. And I think what I would argue is that when we start to include well-being in the story and not just focus on psychological distress or illness, is that we can help empower people to become part of the solution for themselves and to help them build their own level of responsibility and autonomy over themselves and for their family members. So I think that's the big takeaway for me.
All right, thank you, Matt. I'll hand over to Sharon.
Okay, thanks, Ivan. And I guess for me, it's, it is about the listening. It's about having patience and creating space so that that it's not just the people that are able to speak up that you hear from. So, hear from the wide range of people in those communities, and have the patience and tolerance to, and the flexibility to listen to people.
Thank you so much, Sharon. I'll hand over to David.
This has been a fantastic conversation to be participating in, and I thank everybody, both our keynotes and our participants. But what's really struck me here has been the dual focus that we need to recognise between supporting individuals and providing them with the skills, tools and support and coaching that's been the traditional fare, certainly of Life Buoyancy Institute, but then how we expand that out to broader community conversations, and how LBI can be involved in supporting communities, supporting agencies to engage in some of the conversations that we've talked about, to try and get a better understanding of what is the real need, what people want, the skills and supports they have, and how to activate those at the community level, to build wellbeing at the community level. So I'm so encouraged to hear these two conversations, this to and fro between these two perspectives being played out in this webinar with almost 100 people. So it's really refreshing and encouraging, and I look forward to participating in those broad-based discussions. That's it from me, Ivan.
All right, thank you so much, David, and thank you everyone who's contributed.